Hello, everyone, and thank you for joining CareerCert and UT Southwestern today for our telehealth webinar. I'm your host for the webinar, Danielle. At CareerCert, we are focused on providing emergency and healthcare professionals with the training they need to best protect their communities. It's my pleasure to introduce you to our presenters for this webinar. All are Gail Salazar and Virginia Smith. Dr. Rosenberger has over 30 years of EMS experience with over 20 years of adult education instruction. He has performed ground and flight paramedic duties and leadership in town administration during his service. He has served as a faculty member and assistant program director at UT Southwestern. Currently, Dr. Rosenberger is the associate director of the EMS Continuing Education Program at UT Southwestern and an adjunct faculty member for the Emergency Services Administration EAAS program at the University of North Texas, Dallas. He is also the co-chair for the National EMS Education Standards Developmental Revision Team. Dr. Gail Salazar is an associate professor of emergency medicine at UT Southwestern. He serves as the medical director of EMS education and oversees both initial and continuing education of area EMS professionals. He practiced clinically at Parkland Hospital Emergency Department. Dr. Salazar is dually board certified in emergency medicine and EMS and serves as core faculty for the emergency medicine residency and the EMS fellowship programs of UT Southwestern. He's the creator of Campus Emergency Preparedness and Survival Training. His main goal is to improve the quality of education and the management of natural and human-made disasters. Virginia Smith is a licensed paramedic for Cypress Creek EMS in Spring, Texas, which utilizes aggressive emergency protocols, including whole blood in the field. She's currently serving as the in-charge paramedic in ambulance teams responding to 911 calls. Virginia received her bachelor's in biology from Texas A&M and her master's in biomedical sciences from the University of Incarnate Word School of Osteopathic Medicine. Virginia is a medical school applicant and hopes to be accepted and start medical school fall of 2021. Virginia's training has included medical care in wilderness settings in rural poverty in Latin America, where medical resources are limited. And now I will go ahead and turn the time over to our presenters.
Good afternoon, everybody. Thank you so much for joining us this month. We're so grateful once again to CareerCert for the opportunity to join you this afternoon. Our mission at UT Southwestern has always been to shape the way EMS is taught, is practiced, and we want always to bring you innovative, state-of-the-art topics that are going to be interesting to you. And today's no exception. Now, I gotta tell you, we want to push the boundaries a little bit today because not many of you might actually be doing any telehealth whatsoever. One of the reasons we became very interested in working with CareerCert on this, not the least of which the reasons is COVID-19. We really want to be at the forefront in innovation when it comes to care delivery. And we think that a modern EMS organization will be well served by beginning and exploring the conversations regarding telehealth. So I'm hoping to give you all a good, solid overview of what telehealth is. At times give you an overview of what telehealth is not, but I think most importantly to show you several different ways in which you as an EMS leader can look at telehealth to improve the care delivery for your patients. So today we're going to be discussing not just what telehealth is, what it isn't, but we're going to give you some helpful tips, an overview of how to set up an infrastructure, to set up a telehealth program for your institution, and also to discuss some items on how you can go about funding for telehealth. So remember, this is going to be a very broad overview. As the topic matures, I am sure we're going to have many more of these. So I'm really looking forward to it. So how about we get started with taking a look at a very classic case, and I'm going to turn it over to Dr. Rosenberger for the very first one.
Yeah, and I want to echo what you said there, Dr. Salazar. Thank you to CareerCert for bringing this important topic to the forefront of out-of-hospital clinical care. You know, 2020 has been a funny year. Maybe that's not the best descriptor of it, but we've had some bad things. We've had COVID, we've had social and political unrest. But the good thing about 2020 is it's forced us to be more creative, more innovative, and really have an enhanced focus on safety. And so as we embrace the changes that have come in 2020, this is just one more opportunity to embrace distance clinical care. And so again, telehealth is an accepted discipline in medicine, and it should be easily adapted to EMS. And so as Gail has mentioned, we're going to talk about a lot of different things regarding telehealth today. We look forward to hearing about your system and telehealth applications that's within your system of care.
Use that chat function aggressively. We're going to be looking at the chat through Danielle, so please feed us any questions that you have throughout your presentation. Please don't be shy.
All right, so case one, Virginia. Mr. Carter is a 58-year-old man with an extensive history of heart failure, and today he calls 911 for difficulty breathing. As the paramedics arrive, the patient's found clearly in some respiratory distress. You obtain vital signs, and you note that his blood pressure is 173/101. His heart rate is 106. His respiratory rate is 26. His temperature is 97.8. And the capnographer gives you a value of 41. Your patient, this is a guy you know well. This patient tells you that he ran out of his medications because he doesn't have transportation to the pharmacy or to the clinic or to the hospital. And so he's called you today. And again, you know this guy because you've treated him with five different transports probably in the last month or so. And so again, this is a patient that's known to you. You initiate CPAP for this particular patient.
Well, absolutely. I mean, we get patients like this all the time. Just last night, I just had a woman with a VGL of 24, unresponsive. We had to end up drilling her, woke her up with some sugar, and she woke up, exclaimed with profanity, and said, "Oh no, not again," meaning that she had been waken up by paramedics many times before. And it does bring up a frustration that you don't feel like you're making a difference, because these patients do end up in the same place, whether non-compliance, whether some other part of the system, they just end up in the same place over and over again. And yes, this patient that you presented, he is very sick, and you do make a difference in that moment. But it sounds like he just gets back here over and over again. And so this is a big frustration of EMS. Dr. Salazar, I would love to kind of hear your point of view from the hospital side. And do you have the same frustrations as a emergency room doctor that we do? And kind of what are the protocols when someone like this comes in? Is it a treat and send home? Is there other options?
Yeah, this both as an EMS medical director, as an EMS and an emergency medicine educator, as a physician, as a member of my community. You know, while we launched the poll, I want to see kind of how you all would go about fixing this frustration. But yes, absolutely, I do share in that frustration, and I think, you know, it's never a personal one. I think folks sometimes looking on the outside, they feel like we get kind of very personally engaged in this, but kind of the way I look at it is more frustration due to a lack of infrastructure, a lack of medical infrastructure, a lack of financial infrastructure, and accompanied sometimes by significant either psychological, psychiatric, and even sociological considerations for these patients that really create big barriers for them to get the care that they need. So I try to look at this frustration from a healthy standpoint, and this is one of the reasons I wanted to go forth with this webinar on telehealth. So I want to hear from our viewers today So what they think, what would help this patient the most in the long run. And so where we get that, yeah, it looks like the majority of you think that integrating his care within a health system is the best way to go. Now, we can do scripted dispatch protocols and coordinate care on the front end. It sounds really good. Okay. We could have a meeting with the medical director, with the family, and the patient, but all of us have pretty much been in that situation before, and kind of a verbal, kind of come to Jesus type of meeting rarely has a long-term effect. Every so often we do involve social services. Now, some systems have a very robust way of involving social services into the conversation and bridge the gap between patient and the health system. But I think the overall goal should be to integrate this patient's care within kind of the biosphere. You know, the agenda 2050 is going to speak a lot about integrating EMS into the entire biosphere of healthcare. So I agree with you. So Virginia, yeah, absolutely. I do share that frustration. I just try to approach it from a productive standpoint. And so to that end, I want to discuss kind of the conversation on telehealth. So let's frame the entire webinar today on 3 main tenets of telehealth. Number 1 is improved resource allocation. What that means for me is bridging the gap between the patient in the field and the entire health system, and helping to break down those barriers that we discussed a little bit earlier, the financial, the psychosocial, the medical infrastructure. So telehealth is a good way of helping us kind of bridge that gap by creating a bit of a better infrastructure when it comes to those. Patient continuity is the second big tenet that I want you to keep in mind. We have shown time and time again that having an established care team is far superior than the patient who needs frequent emergency interventions, frequent transports. They get to see a different crew, they get to see a different hospital, get to see a different physician, different set of nurses. We've shown time and time again that having an established care team for the patient in the long run is far more beneficial than this kind of sequential care. And last but not least, remember the following, that one of the big advantages to telehealth is risk reduction. And it's not just the litigation aspect of it, like we decreased our chances of lawsuits, et cetera, but think about the decreased morbidity and mortality advantage that telehealth has. So I'm hoping that as we go throughout the webinar today, you remember these 3 tenets, and we're going to tie them in really nicely into EMS today. So next slide, please.
Dr. Salazar, so let me add a little bit to this patient continuity. You know, when you talk about that and integrating EMS, the pre-hospital piece, into the hospital, that system of care, something that comes to mind, I was involved in a research project that you're probably pretty familiar with, Get With the Guidelines. And I was able to, it's really a really cool opportunity as a paramedic, but I was able to go out and meet with some of these patients. Again, they were randomly assigned, and the researchers themselves didn't know who was getting the in-field care and who was not. But I'm going to call this gentleman Norman. And Norman was an urban inner city dweller, clearly poverty struck. This gentleman was probably mid to early 50s. He had CHF, and he made a lot of visits to the ED, particularly when he got fluid overloaded. And as you know, pretty much what you guys are going to do as physicians in the hospital is do a really good assessment and drive them up. But this poor gentleman really was non-compliant with his directives and his medical care. He just really didn't have really good access. His only access was 911 to the hospital. And, you know, as I worked with this gentleman, we got pretty close and got to talk to a lot of different things about his care. And what I noticed mostly was that the poor guy was unable to navigate the healthcare system. And so telehealth and patient continuity and risk reduction could certainly help this gentleman manage his CHF better.
What you're describing there, Paul, that's a classic example of the second aspect of it. You mentioned patient continuity. We talk about telehealth allowing the patient to have what we call longitudinal care and continuous care as opposed to sequential care. And so really what this gentleman needed was definitely improved resource allocation, better patient continuity, and I guarantee you that if a good infrastructure for care for him is established, the risk reduction for the EMS agency that takes care of him and the hospital's health system that cares for him is going to be reduced.
Yeah, I mean, some of his biggest needs were just navigating insurance and getting access to the local clinics for his CHF care so that he didn't have to call 911 or use the ER.
Absolutely. So let's talk a little bit about how telehealth kind of works within the atmosphere or VMS. Paul, if I could have the next little slide, we're gonna talk about the next case and we're gonna tie that into. So Virginia, go ahead.
Yeah, so in this case, the paramedics walk in and there's a 76-year-old woman with a history of frequent falls. The family saw her 4.5 hours earlier and she was well. We arrive, we do an examination, and she has a small hematoma on the temple region, and she responds non-verbally to simple commands, but is unable to move her left arm. We get a set of vital signs as listed there: blood pressure 152/93, heart rate 97, respiration 16, temperature 98.1, capno 33. So the paramedics debate whether to transport her to the nearest trauma center or primary stroke facility. And if I were on scene, I think a big part of telehealth and how Dr. Salazar was saying before, there is an advantage of paramedics walking on scene and seeing everything that's going on. That's sometimes that translation is not carried over to the hospital. But like looking at this, I think I would go to a trauma center because just with the information I have, that's what I think is kind of the cause. That's what I think is causing the left-sided weakness, and due to her history and due to the information I have available. But I think that is a really risky move. I wouldn't be 100% confident in it. Dr. Rosenberger, what would you do if you were on scene in this situation?
Let's launch Paul. While Paul gives an answer, I want to see what our friends think too. So Paul, what do you want to do?
Oh, I just want to be difficult here. So I'm going to treat her for stroke and take her to the stroke facility just to be different. But like you said, I think this patient could go either place, whether it was the trauma facility because perhaps trauma caused the head injury here, or perhaps she had the fall because of the stroke. And so because our diagnostics in the field aren't as robust as they are at the hospital, we probably don't know which facility to go to.
Well, for those of our viewers who are joining us today who work in an urban environment and their level 1 trauma center is also a comprehensive stroke center, kudos. You have, this is a no-brainer for you, but we don't always live in a perfect world, and many of you are going to practice in a place where you may have a level 2 or even a level 3 trauma center, and your stroke center might be a primary stroke center at best. So I'm really curious to see kind of where folks fall into this one, this chicken or the egg type of conversation. So was the weakness from a stroke what caused the fall, or did she fall and now she's got a head injury and now she's got stroke-like symptoms? So I think most folks will go to a trauma center. A couple of you would call a stroke center. I couldn't get anybody to bite on calling medical control, and I commend you for that. So let's be decisive on it. So how on earth can telehealth work here? You may start forming some ideas. So let me tell you about how we can involve telehealth and EMS. So to bring the case to a close, you decide that since the patient had been having some weakness and she felt maybe the stroke came first, you take her to a primary stroke center. The initial CT is positive only for a small scalp injury, no intracranial, no brain hemorrhage. The docs over there, my colleagues, obtain an MRI. It's consistent with a large vessel occlusion, right middle cerebral artery is also affected. The patient undergoes thrombectomy, and she does quite well with minimal residual symptoms. So yeah, it sounds like the medics chose kind of the chicken or the egg, whichever way you want to look at it, but this is a tough decision to make. So how does telehealth help here? Let's talk about 3 ways that telehealth is going to be useful for you. First and foremost, telehealth can be a phenomenal triage decision maker tool for you. I am a big fan, once again, of talking about how we bridge the gap between the scene and the patient's definitive care. So for me, triage doesn't just mean figuring out where kind of patient is going. To me, true triage means making decisions that are going to affect the ultimate outcome as early as we possibly can. So the earlier we make the correct decision, the earlier the patient can receive the definitive care, the more likely we are to obtain the best outcome for the patient. And so I think telehealth is a phenomenal way of bridging that gap that currently exists. And once again, breaking down the barriers, not just in infrastructure, but medically and for definitive care. The second way is communication. So the majority of you probably communicate by cell phone or by radio. You may have a medical control that does some of your kind of a go-between, or you may communicate directly with hospitals. How awesome would it be for this crew to have an established infrastructure for communication with a receiving hospital, so that you can speak to an emergency physician or say a neurologist in real time and say, Doc, I have a 76-year-old lady who was having some weakness and she fell on my exam. She's got X, Y, and Z. Right now, I am trying to make the decision on where the patient should go. I think the patient should go to a trauma center. What is your opinion based on what you're seeing? How awesome would it be to have an awesome, good infrastructure for hospital communication?
And Dr. Salazar, I'd like to
Yes.
add a point to that. Sometimes, especially with some neurology, we are in a situation where we might have to take the patient's airway or administer paralytic or sedative medicines. We are a little bit worried that the neurologist cannot do their full assessment, because a stroke is a little bit more complicated to diagnose than a Cincinnati stroke score or race score. And the neurologist has their own set of protocols, but if we, knock the patient out, they're not the same as they were on scene, we kind of take away that assessment. And so this would be an awesome opportunity for the neurologist to do their assessment to the best of their ability over telehealth. And then we could take that airway or administer whatever medication we need without having to worry about taking away those tools from the neurologist.
And if you think that EMS is the only one that gets yelled at sometimes for the decision to sedate somebody or put them down for an airway, I am also not immune to that. And that's actually one of the most frequent kind of places of conflict is like, what do you want me to do with this patient now? I can't do an exam. They're on a paralytic and fully sedated. So your point is very, very well taken. How awesome would it be to have a neurological exam done before you need to put that patient down if an airway is unstable? So yeah, I really like your example. And let's remember too, to point number 3, that when I taught you in paramedic school, one of the things that's near and dear to me is the fact that medicine is a dynamic process. Emergency medicine, these patients change on you, and each and every one of you know that. So the capability of interfacing with a receiving facility, a receiving physician, and being able to convey that clinical change in status in real time, especially when there is a visual component to it, to me is really exciting. It's truly a second eye on the patient, if that makes sense.
Dr. Salazar, let me add an illustration of that. So back in the day, I actually was a flight paramedic. And what comes to mind is a patient that we were flying. I love giving my patients names, so I'm going to call this gentleman Cardi. But we were transporting from a rural facility into our facility. And this gentleman was having an active MI, and we were giving him TPA in flight. And as you well know, as these patients reperfuse, you can see dynamic and really dramatic EKG changes. Those ST segments come back down to the baseline really doggone fast. And so we were watching that happen as we were administering this TPA. I do have to say that he did have the TPA checklist. He was certainly a candidate for it, but bad things happen. And a bad thing did happen in flight. This gentleman was on the headset at the intercom system with us in the helicopter because of all the noise, and we were talking to him. And then the next minute, he's unresponsive. And myself and the nurse knew immediately what had happened. This poor gentleman ended up having a hemorrhagic stroke because of the TPA. We immediately stopped the TPA in flight, but unfortunately, we didn't have a mechanism to talk to a neurologist, an ER doctor, or a cardiologist. And telehealth would have given us that opportunity to, to give us a second eye for this particular patient. Unfortunately, his outcome was very poor, but having that telehealth or the second eye would have been very beneficial to us.
You're really there at the mercy of time, at the mercy of height, and telehealth helps you bridge both of those very, very quickly. So these are two classic examples, the one Virginia that you provided, and Paul, the example you provided. Tell us about where telehealth is prime and ready to rock and roll. And neurology, it goes without saying, the care of patients with stroke has evolved dramatically. It's not just about last well known or even just TPA. Now with large vessel occlusion strokes, we have the capability to do thrombectomies and go pull out some of these clots. Our understanding of how myocardial infarctions evolve. Now we have the term occlusive myocardial infarction, and my dear friend Ray Fowler, who's listening here today, I would love to get him on one of these webinars to discuss occlusive myocardial infarction. So the care of these patients can be bridged very, very seamlessly with a good platform. So let's discuss the next slide here, Paul. Let's discuss some areas in which EMS telehealth can also be applied. Of course, neurology and cardiac care is one, but let me tell you about one that is kind of the rock star right now, and that's psychiatric care. I'd be more than happy to share with you a study out of a university that showed that telehealth for patients with psychiatric illness proves to be more effective and more cost effective as well than in-person visits. And remember, although that is not exactly EMS, you can see the potential here. So here is why. Number one, psychiatry lends itself really, really well in patients who are well compensated, don't have an acute crisis or decompensation. That patient population lends itself really nicely to tailoring of medications, either by EMS or tailoring their own medications. And for that reason, patients can receive a much better seamless care in real time with medication management. Could be something as simple as you run on a patient who has increasing anxiety, panic attacks. Could the care of that patient be optimized instead of having to transport that patient to have an interface with her mental health provider and be able to say to the patient, why don't you up your dose of your antipsychotic or your anxiolytic for today and give me a call so we can set up a virtual visit later on and possibly avoid that transport. So that's a thought for you. The second big aspect is crisis coordination. For those folks who are absolutely decompensated, who may be suicidal, you may be on the side of the highway trying to de-escalate a patient. how amazing would it be to have a mental health professional available to you in real time, especially if they know that patient, to help you de-escalate the situation a little bit better, give you a little bit of information about the patient, about strategies on how to take care of them. That to me would be an incredible tool to have in the field.
And hey, can I chime in for a second?
Sure.
This is probably not widely known, but the number four, 1, 2, 3, 4, the number 4 call that's answered by EMS today is related to psychiatric emergencies. And that's coming from the NMSIS data set. So, you know, we see a lot of patients with psychiatric or mental illness.
Well, out of if it's number 4, out of those patients, can you imagine the number that do get transported to the hospital? And we have increased wall time because not every facility has a mental health professional available 24/7 or a police or security force to help you with that patient. I think the ground is pretty prime and ripe for EMS to integrate a seamless real-time interface with mental health professionals. And then think about the types of environments in which we take care of these patients. One of the ones that we thought about when we were designing this module, for example, in shelters for the unhoused. By the way, I've gotten away from the word homeless, and we can do a whole webinar on why that is, but I prefer, these patients don't have a physical home, so I prefer that the term is unhoused. But one of the areas, particularly in our region, where we get quite a few calls, 911 calls for psychiatric care, are patients in shelters who really, not only do they not have access to a physical house, they don't have the financial resources for their medications, and their medications get frequently stolen. So we find ourselves kind of being in the middle of a very bad social medical problem. So, for example, during Hurricane Harvey, how many of our patients that came to our mega shelter were out of their medications, and we wind up having to transport them to the hospital, when it would have been outstanding to me to have a dedicated mental health professional available to us on scene so we could take care of that patient. So I think that the time is right for EMS to consider integrating telehealth into the care for our patients with psychiatric emergencies. Some innovative applications, as many of you are well aware, both political reasons and definitely medical reasons. Our patients near the border to Mexico, for example, and a large immigrant population are faced with many medical emergencies, many physical complaints, and EMS is at the forefront of that. So if I am Mr. Salazar and I am trying to tell you que me duele mucho el estómago y no he tenido mucha hambre, he estado vomitando muy frecuentemente, and you don't know anything regarding Spanish, it would be amazing to me to have the capability to interface with a Spanish-speaking clinician who can help you not just with the interpreter services. I think a much better care for these patients would involve actual real-time consultation and maybe perhaps finding ways of taking care of this patient in real time.
And Dr. Salazar, I think a point to bring up is a lot of us have learned Spanish or can navigate Spanish, at least for the field, but there's other languages out there too. We have a high population of Vietnamese speaking, and I have no idea when it comes to them. And so there's a lot of different languages besides Spanish where these interpretation telehealth could be very, very helpful.
Imagine too, in some cultures in which a female patient is faced with an all-male EMS crew and making the exam and the history taking a lot more difficult for cultural reasons. Having the capability to interface with a facility that features female physicians or clinicians that will make the patient feel at ease and help you with your assessment and the treatment for these patients, to me, it just seems like the right thing to do. Then rural medicine as well. Many of you practice in true rural environments, and your access to receiving facilities and your access to services may be very limited. I think that EMS would be well served by having the capability to interface in real time with these facilities and really bridging the access gap that exists. My dear friend Paul Rosenberger and I have been very involved in sports medicine. So Paul, tell us a little bit about kind of how sports medicine is lending itself nicely to telehealth and EMS.
Sure. So we've worked with a large national EMS ambulance provider, and we have developed a head trauma life support course. And really the focus of that course, of course, it's head trauma. I think every paramedic gets a lot of training on head trauma. Unfortunately, when you go to the EMS textbooks and you look up concussion, you're going to find that it's probably one paragraph, maybe two. And so we put together a course that involved significant head trauma, but we really focused this particular course on concussion injury and backboarding and spinal care and all that kind of stuff. But this really came about because of an idea of this large national EMS ambulance provider. And this provider does professional and college level standbys like racing, football, and even into professional baseball. And their thought is that we wanted to take this concussion assessment and this concussion knowledge to the providers who do standbys every Friday night at a high school football game or soccer. And those places have a lot of concussion injury, believe it or not. Your high school football games on Friday nights, that's tonight. Or those soccer is actually a sport that there's lots of concussions with that. And so the true application to this that our facility's been involved with is the Telehealth Robot, where when a player gets an injury that is suspected to be a concussion, they can use this robot to talk to a neurologist, and that neurologist can do an on-the-sideline assessment of the injured player and determine if this is a concussion or this is not a concussion, and what exactly needs to be done based on the findings that's done through telehealth and a SCAT-5 assessment and those kind of things. But it's really a cool application and very beneficial for the community, especially the high schools, the athletes who are playing soccer and football.
So all of a sudden your crew who may be on standby, maybe an extra job on the side, they can actually interface directly with a specialist in concussion care and even coordinate the care with the athletic trainer, for example, perhaps even avoiding a transport to the hospital and taking that crew at a service or an ambulance at a service for something that can be taken care of by an athletic trainer. Additionally, both QI and credentialing are applications for EMS telehealth that are prime. So Virginia came up with an example that I thought was fascinating. Tell me a little bit about that.
Absolutely. The agency I work actually has these Axon cameras with the ability for live view. So our supervisors and our medical directors can look in real time and see the patient and what we are saying to the patient. And so I just finished training for in-charge paramedic, and one of my medical directors actually got on live for some of my calls, saw how I interacted with patients, saw how I managed a difficult patient and an urgent patient, and then had written down notes. Unbeknownst to me, I knew someone was watching. I didn't really know who it was. And so I go into Clear, and she had these questions and she had these points that she wanted to talk about what I was making in that decision, why I made those decisions, and was confident with my decision making and therefore cleared. But we wouldn't have had that opportunity for her to see how I work as a paramedic unless we had these real live view where the medical doctor could see that real time.
Yeah, and even though this example is not exactly what you think of when you think about telehealth, it really is telehealth. literally is using technology to bridge the gap from what's happening on scene with the QI process on the back end and kind of really merging both of those. So I beg you as an EMS leader considering telehealth that you look at all of these and consider the benefits. So let's see what we got next there, Paul.
All right. So case 3, your EMS agency is contacted by your main receiving facility to discuss participation in the development of an aggressive readmission and prevention strategy revolving around patients with diabetes. And so basically the scenario here is the hospital's reaching out to EMS to talk about how they can reduce readmissions and prevent some of these problems surrounding diabetic patients. You're wanting to prepare for this meeting, and so the question becomes: is how do you prepare for this meeting? What are some of your thoughts, and what will be that role of that out-of-hospital provider? So just kind of things you would think about before you actually arrive at this particular meeting.
So while we launched the poll, I wanted your opinion on really if you had to pick one. I know it's probably more than one good answer here, but I want you to pick one, and I want you to let me know one topic that you want to discuss. And if you're involved in EMS leadership, especially in an urban environment, at some point or another, if you haven't yet, I know we have for sure, the conversation will start happening about integrating the care of patients in the field with the care that's being provided and the resources of the health system side. So you're going to be, and EMS is always invited to the table for these, and the reasons are very, very clear. We definitely have the patient volume. We are really what feeds a good chunk of patient volumes to these receiving facilities. And so in any readmission prevention strategy that a health system has involving EMS is going to be the smart thing to do. So I'm very interested to see, you're sitting at a meeting with a bunch of people in suits and some white coats. You got some nice bagels, and let's say this is post-COVID. So I want to hear your thoughts about, give me the topic that you would pick. Is it, where's the money coming from? Or is it going to be what technology you're going to use? What are you dealing with in terms of volume, or your role for EMS in the project? So it looks like the majority of you want to know why the heck are you even wanting me at the table? So all good answers for sure, but I think the majority of you really want to find out kind of what your role is going to be in the project. So let's discuss a little bit about this case and see how we can tie it into our discussion on telehealth.
This is the merger of the community paramedic, with telehealth, and the fact that we're already there within the community, serving the community. So I think this is a nice transition to community paramedicine as well as telehealth.
Absolutely. I think that once you understand your role, you realize that you feed the majority of patients to this hospital, particularly diabetic patients. They've called you to the table for a reason. So it's going to be pretty clear that to some degree, they want you to reduce the number of diabetic patients you bring to their facility for various reasons. Probably my biggest question at the table, once having understood what the scope of the project is, how the heck are we going to pay for this? So as you're setting up an infrastructure for a telehealth program, I think the first question you got to ask yourself, once you realize that you need it and that it's a good thing, it can benefit the entire healthcare atmosphere in your region, it's going to be how you pay for things. So we know, having looked at the data and a market analysis, that there are really 3 big patient populations that actually have resulted in savings, not just in readmissions, but clinic hours, personnel resources, etc. The first one is psychiatry. That's been the biggest one, and we discussed a little bit earlier about why that is. I think psychiatry lends itself nicely, as we discussed. The second one that's maybe a little bit surprising, and I'll tell you, why I think that is dermatology. Okay, I think psychiatry and dermatology share a couple of features, characteristics that lend themselves nicely to telehealth, and that's going to be that they mostly rely on both verbal and visual examination. So psychiatry is mostly a verbal communication, reading the patient's affect, for example, and dermatology is all about looking at the skin. It's mostly a visual examination. It's mostly listening to how it started. Is it itchy? Is it painful? How long it's been there, etc. So these two disciplines lend themselves very well to telehealth. So I'm not surprised that they've resulted in good financial numbers. And diabetes is the third one. So Virginia and I were discussing when we were looking at the data and looking at developing this webinar about why that is. So Virginia, what are your thoughts on why diabetes has resulted in good revenue?
Yeah, well, I mean, I don't know for sure, but just a guess is that usually with diabetes, it's the more emergent is hypoglycemia, which EMS providers can kind of treat and fix and are comfortable enough, like with the right support and the right fix, to leave the patient at the house, and because the problem is no longer. Where with CHF, COPD, often the emergent cannot breathe, you can't treat and then fix. Like you can't initiate CPAP and that's working and then take it off and they're good. You have to transport, and there's a lot more involved to it. So I think maybe that's a little bit part of the diabetes versus CHF and COPD. And I think another big one is that a lot of times caregivers are very involved, and especially in this day and age with COVID, caregivers can't go to the hospital, or there's a limited number of people that can go to the hospital. And so often they're getting this information from the doctors secondhand from the patients. And when a patient has a caregiver, a lot of times maybe they might not report all the information, they might not know what questions to ask. And so giving the caregivers a chance to talk to the doctors via telehealth, ask all the questions they need to, especially with this COVID, I think also would be beneficial for the patient to reduce readmission.
And almost surprisingly to me, I was learning from my colleague Stan McDonald, who helped me a lot with this, developing this presentation, that heart failure and COPD don't lend themselves very well. They haven't resulted in really true successes financially. So although there are some really good success stories, it's surprising to know that overall they haven't resulted in nearly the same amount of readmission reduction as was hoped. And so Paul and I were discussing potential reasons why, and I think Paul mentioned earlier with Mr. Norman, there is a lot more involved, including things like access to healthy food, low salt, the concept of food deserts. And if you haven't heard that word before, it really involves the inability for certain patient populations in certain areas to have access to healthy food. So Norman lived in an area where there are no supermarkets, and all he's got accessible to him at any given time is fast food.
Yeah.
And COPD, go ahead.
He, this gentleman, I worked with him really hard to get him to eat better, because really what he experienced was whenever he had French fries, particularly French fries with a lot of salt, that's when he started having his problems with his CHF. And so I said, Norman, we got to get you off the French fries. And he said, well, Paul, how do we do that? The only thing that's available to me is a fast food hamburger restaurant that's in very close proximity, particularly where he could walk. And so that's what he did. That was his food desert. And so it becomes a little bit more complicated than some of these other things, because you have to change patterns and eating and nutrition. And again, I helped this guy with, I went to some of the nutritionists in the School of Allied Health. And we developed plans and things like that for him, but he just never enacted those.
And for COPD, I think the reason is it's so dependent. Virginia said respiratory emergencies are rarely something you can kind of treat and release unless it's maybe on complicated asthma. But, they run into other equipment issues. For example, I ran out of my oxygen, for example. And so it becomes really difficult. And you can imagine when there are so many barriers to the patient receiving good care at home, it makes telehealth not a financially viable enterprise. So when you're talking about funding, I think that the most fruitful ones for an emergent EMS system are going to revolve around psychiatric care, diabetic care, and as the system matures a little bit more, you can start looking at things like heart failure and COPD, particularly if coupled with a community paramedic program. Let's move on to the next one, Paul. Here are some strategies for your system to get involved in telehealth and get the technology that you need to establish a telehealth program. I think that the biggest bang for your buck is going to be to become acquainted with accountable care organizations or ACOs, which are part of hospital systems. Got to remember that hospitals want some of your transports. They want your STEMIs. They want your strokes. Some of them want your trauma. These accountable care organizations also want to keep some patients out of the hospital and having to admit them, your heart failures, your COPDs, your diabetics, patients with psychiatric emergencies. So when you're thinking about funding for these, it's well worth your while exploring the accountable care organizations within your region at your main receiving hospitals. And you might actually be tempted to start the conversation about, can we contribute to your mission as an accountable care organization by if you give us the resources to establish a telehealth program that is going to result in you being able to provide better care for your patients, get some cool toys to play with, potentially decrease the number of transports to the hospital. So if I'm an EMS leader, I'm going to approach health system X and ask them about what their ACO is currently doing. Additionally, there are many grants at the federal and state level for technology and innovation. So yeah, you can get grants to get more tourniquets or perhaps some more seats at a local conference or maybe some more backboards. For example, let's start looking at some of these technology and innovation grants so that we can take a look at how to get the technology that we need to take care of our patients using this platform. Since we have a few minutes left, let me tell you a little about the infrastructure. Now that you know that there are advantages to it, you have a patient population that needs it, you know how you can get some money. Let's talk about the actual infrastructure. COVID taught us a lot about telehealth. I would have never dreamed that we'd be using so much telehealth and that it would be so successful. And it kind of pushed us into a corner to be more innovative. And by gosh, we were forced to do it, and we figured out it actually works. So a couple of a little bit of lingo for you. These telehealth platforms are called suites. The majority of them are HIPAA compliant, though some of these platforms, including at the federal level, have loosened their restrictions due to COVID-19, so patients can have better access to the care that they need. These companies are going to charge for their suites using a variety of models. The most common one is kind of by licenses or number of users. So if you're an EMS agency, you can get, say, a license for each of your ambulances so that you can interface with your receiving facility, nicely paid for by your ACO. Some platforms and some suites are paid by the minute. That's a much far less common approach to things. And one caveat to it is that it does require the patient to possess a communication device. One thing that we learned during Harvey at the mega shelter when we were trying to develop this telehealth program is we were really concerned about patients, do they even own a cell phone? Surprisingly, or not surprisingly for that matter, the overwhelming majority actually had a cell phone with the capability to download an application. So though it is a requirement, the patient have an interface, you can imagine that EMS can actually have that platform, that device that the patient can use to interface with a clinician on the hospital side. So those barriers are not very big. I think the biggest key is going to be to figuring out, is there a market for telehealth, an opportunity for your system, and is the funding going to be available? And we gave you some pointers, and now you kind of know what the infrastructure is going to be. In Virginia, the services are both synchronous and asynchronous. Synchronous meaning in real time right now. But at the hospital side, the asynchronous ones are going to be like, doc, I'm going to upload an image that you can look at a couple of days later. That is not a good one for EMS. Amongst the biggest concerns that I have a couple, but here are the big ones. Discoverability. If you're going to utilize one of these suites, one of these platforms, I fully recommend that they have the capability of being encrypted. And if you encrypt them, they're more than likely going to be HIPAA compliant. Some clouds that these suites live in may not be HIPAA compliant. So when you're making the preparations to deploy and implement your telehealth strategy, I really ask you to take a look at these two things. Are they using encryption? Is your cloud discoverable? And once again, not only are we reducing morbidity and mortality, but we're decreasing our litigation rate. And I think the last piece for you is that my recommendation is implementation strategies for your telehealth program. I think that program, that suite, needs to have the ability to communicate with your electronic health record. I think redundancy and duplicating efforts is going to make it impractical for your crews to want to go through a process like this. So how awesome would it be to integrate that conversation you had with the neurologist about the patient in case 2 directly into your electronic health record? So we're at
Dr. Salazar, there's a question that someone has brought up to our attention, and I think it merits some thought. The question basically is, how do we help with this older generation, which is a lot of these types of people, with the technology? Since with COVID and Zoom, everyone's trying to have experience, trying to educate older populations on how to use Zoom, and sometimes it just doesn't click, it's not going to, and there's a delay. What would be your suggestion maybe for that concern of the ability of the senior citizens to use this technology?
I think developing a champion community to help both our patients on the patient side and the EMS side, so it would be the way to do it. So the community knows in advance that our agency that is going to be taking care of our senior citizens has this new technology, and we have champions both in the community side and EMS side who can not just inform the public about the technology, but hold webinars, for example, face-to-face interaction. And EMS also has the capability of being educators at the same time. I'm a big fan of using community champions for this.
Hey, Dr. Salazar.
Yeah.
Actually, it's a great question. I just had a Zoom call with my entire family last Saturday night, and one of my family members, of course, is my mother, and she's probably about 85, 87 years old. I'm not exactly what her birthday is, I'm ashamed to say, but man, she was in there running the Zoom call like a champion, and I don't know who taught her that. It wasn't me, but I would dare say that one of my brothers and sisters did. And so I think, that's the role of the caregiver or the family member that can educate them on how to use Zoom.
Yep, it's true definition of having community champions. There's no other way besides somebody who can actually take the time, that has the knowledge, the expertise, and the ability to communicate with these patients. I think that's the best way to integrate this technology into our community setting. So it is 101. We don't want to take too much of your time. We are so very grateful for the opportunity to speak with you today. If you need anything at all from us, please shoot us an email.
Thank you so much to all our presenters, and thank you everyone for joining us today. Visit us at CareerCert.com to access this webinar at a later date or other free resources to help you improve patient outcomes. Thank you again for joining us today, and thanks for all you do to make our communities safer places. Take care.